Dear friends, I'll be speaking on advances in IOL technology. So after the cataract is removed, then what? Today we have an array of multifocal intraocular lenses available, different types, different companies, because patients basically want spectacle independence. Like Dr. KPS was saying, 6 and 5 they want, and today cataract surgery has turned into refractive surgery. What are the limiting factors of the older multifocal IOL designs? Decreased contrast sensitivity, poor intermediate vision, and pupil dependency, especially the refractive IOLs. So they did not become widely accepted. There were some patients who are not very comfortable with it. The newer generation of IOLs, you have most of these problems that have been overcome. You have the trifocal multifocal IOLs, the extended depth of focus, pinhole IOLs, light adjustable lenses, accommodative lenses, and now capsulotomy fixated lenses. I'll be discussing these. The trifocal lenses are the fine vision, laser tree, and you also have some of the Indian lenses.
Thank you.
Typically the laser tree is what I have been using and had the experience. It's got a central 4.34 mm trifocal zone and a peripheral bifocal zone. There are fewer rings on the optic surface compared to the bifocal predecessor, so the quality of vision is better, quality of night vision is better. The PanOptics is a new platform from Alcon, which is based on the Acrysof IQ platform, and it has the same hydrophobic acrylic material and same mechanical design as the IQ. It has got a proprietary diffractive technology to optimize near and intermediate working distance. And if you look at the distance, the PanOptics has 15 rings, and it's got a plus 3.25 add for near and 2.17 diopters for intermediate vision. If you compare the trifocal with the PanOptics is basically a quadrafocal technology. The trifocal technology focuses for distance, 80 centimeters and 40 centimeters, but it's found that the most useful intermediate vision is at 60 centimeters. So the PanOptics has a quadrifocal technology, and it has got 4 points of focus, 40 centimeters, 60 centimeters, 120, and distance. But what happens is they say that they have something known as the Enlighten optical technology, where there is the light from the 120 centimeters is redirected to the distance, and so effectively it has got 3 foci, but you get a 60 centimeters intermediate, which is useful. So the benefit is full range of vision for distance to intermediate to near, and preferred intermediate vision at 62 centimeters. Less pupil dependence performance because the central diffractive optic is 4.5 millimeters, and the light utilization is highest at 88%. This is a comparison of the lenses between the Zeiss, Alcon, and the fine vision. You can see that the near add is the highest with the fine vision, followed by Zeiss and then Alcon. The intermediate light energy is the best with Alcon, and Alcon is hydrophobic, other two are hydrophilic. The EDOF lenses are again a new family of lenses. You have the Technis Symphony and the 80 Lara. Mechanism of action of the Symphony is it has 2 mechanisms. One is a proprietary HLET design feature which extends the range of vision, and then achromatic technology which reduces chromatic aberration. The HLET design is the relief of or profile of the lens, the height differential in each ring, and the HLETs are optimized so that there is an elongation of the focus due to constructive interference of light from different zones, and this is how you get an extended depth of field. It is also combined with the proprietary achromatic technology which reduces chromatic aberration and increases the available light. Normal eye has about 2 diopters of chromatic aberration, and this is reduced in the Symphony. The Zeiss 80 Lara is again a EDOF lens, and it gives spectacle independence for intermediate and far distances, less visual side effects and night vision disturbance than multifocal IOLs, and it's a diffractive aspheric optic and has a extended depth of field of about 1.9 diopters. It's supposed to have less visual side effects because of what is known as the SMP, or the smooth microphase technology. There's a smoothing out of the ridges which reduces the scattering of light. Next you have the small aperture IOL from AccuFocus, the IC8. It uses the pinhole effect and causes a defocus of about -2 diopters. So essentially a +2 add. The pinhole effect is more forgiving for refractive errors if your biometry is not on target. It gives good stereopsis over a range of distances, better night vision than the trifocal IOLs, and it's also tolerant to astigmatism of up to 1.5 diopters. It's got a central aperture of 1.36 mm, the aperture size, and it has got PVDF and nanoparticles of carbon which make up the mask. The drawbacks is there is a slight reduction in distance visual acuity. There is minimal loss of contrast sensitivity, but it does not provide as much near-eye as the trifocal, so reading may be a little difficult. Another very interesting development is the light adjustable lens, or the Caloan lens, where you can adjust the refractive error after the surgery. You can also correct myopia, hyperopia, astigmatism up till 2 diopters, and you can also create a presbyopic effect. The dominant eye is made emmetropic. The non-dominant eye, you can induce -0.23 microns of spherical aberration that gives an extended depth of field and gives intermediate vision. This is a photosensitive adjustable foldable 3-piece IOL. It's basically made of silicon. It's got photosensitive macromers in the matrix, and then you can use a UV light basically mounted on a slit lamp to cause polymerization of the macromer, and once this is done, the free macromers actually diffuse to the center and increases the central thickness and increases the add power of the lens. The drawbacks is there is a slight reduction in distance vision in the non-dominant eye, and less near vision than a multifocal IOL, and also patients may vary in the tolerance to spherical aberration. You also have accommodative lenses. The various accommodative lenses that came in, the most popular was the Crystal lens, but then most of them have not worked very well and have become obsolete, so I'm not going to touch on them. The maximum advantage of a accommodative IOL is there's no loss of contrast, no glare and halo, and this is something that work is being done on. Another very exciting development is the femtosecond laser IOL refractive index shaping, where post-op you can actually correct any refractive error by using a femtosecond laser in vivo. And the system uses a green light 520 nanometers and 28 microjoules of energy to rearrange the chemical bonds with the polymeric material, and you can use it on hydrophobic lenses. The potential advantages are targeted laser can create a refractive index shaping lens within an existing IOL to correct and alter the power of the existing IOL, and there have been studies done on rabbits which show it is quite safe. Then you have the capsulotomy fixated IOLs. The typical capsulotomy fixated IOLs were bag in the lens, lentis lens, the masket lens. This is basically to avoid dysphotopsia, and the lens gets fixated onto the capsulotomy, preventing any rotation, tilt or decentration. So with the previous lenses, the potential limitations were removal of OVD from the bag behind the IOL is difficult. The designs are complicated. You need special instruments, and sometimes you can get capsular tears. You need a femtosecond laser to get a perfect rhexis. I designed a new capsulotomy fixated IOL, and I've been presenting it. It is single piece open loop hydrophilic. Now it's available in hydrophobic IOLs. We are still doing the tests. It has 2 extra haptics at 3 o'clock and 9 o'clock position made of PMMA, which can swivel over a pivot. So I'll just show you a short clip of how this is the lens. You put it in a regular cartridge and an injector. You inject it into the capsular bag, you can use it either after femtoflex or regular conventional phacoemulsification. Once it's inserted into the capsular bag, then you can use 2 dialers to rotate the swivel haptic over the anterior capsule and capture it. So you can go on to the other side and do the same. So once it's captured onto the capsulotomy, the lens is very stable, it's well centered and does not rotate. It's also more anterior in position. So you can see that we measured the antechamber depth and it was very stable over 1 year. There was no change. So the ELP effective lens position is very stable and fixed, so you don't get much of refractive surprises. The UBM shows that it's more anterior, so you don't have any dysphotopsia. Potential advantages, simple design, standard injector, you can use it with flax or manual phacoemulsification, stable fixation and ELP, good centration, no tilt, rotational stability for toric designs, minimal or no dysphotopsia, and if you want to explant it also, it's easy. Thank you very much for your attention.
Now, the more few remarks.
That is a very nice presentation, Sri Ganesh.